Hi, I'm John Piccini at Duke. I'm very happy to be here to cover this exciting science that's being published in JACC today. I'm here with Dr. John Whitaker from Brigham and Women's, who's presenting some very exciting science here at the Heart Rhythm Scientific 2022 sessions, and again being published simultaneously in JACC. Welcome, Dr. Whitaker.
Thank you very much, Dr. Piccini. Thank you.
So tell us about the study. It sounds really exciting.
Well, thank you. So we've actually looked at our ablation cases of moderator band and right ventricular papillary muscle ablation over the last few years at Brigham, and compared a group who we used traditional radiofrequency ablation and those who actually used cryoablation to overcome some of the challenges associated with catheter stability and automaticity when ablating these arrhythmias. And we were happy to sort of demonstrate with this data that the acute performance of cryoablation, as well as the medium-term follow-up, was actually even superior to that of radiofrequency ablation. And it's something that's now become part of our standard of care, even as a first-line therapy for the ablation of moderator band and right ventricular papillary muscle PVCs and ventricular arrhythmias.
Well, that's really interesting. Many times when we're in VT ablation, we try one technique, and if we don't see the result we need, we may recruit a second technique, particularly when the anatomy is difficult. In these cases, did you have any where both techniques were used?
Absolutely, yeah. And there was a cohort of cases where RF was tried, and because of either catheter stability or hemodynamically unstable automaticity, it simply wasn't possible to achieve success, and so the cryoablation catheter was brought in at that point. And so that was our testing status, if you like, before we actually moved towards using it as a first line, recognizing that these issues are actually fairly common when we tried with traditional RF.
Gotcha. And tell me a little bit more about the setup. I imagine these were all done with intracardiac ultrasound.
Absolutely, and I think that was a really key part of this because, as we know, visualizing the cryoablation catheter is much more challenging within the mapping systems. So actually localizing it with intracardiac ultrasound was absolutely critical. And of course, in doing so, we were actually able to confirm that we had good adherence with the cryo catheter and could see that ice ball forming, which was reassuring from an anatomic point of view that we were delivering the treatment where we wanted to.
Gotcha, and this is a 6-tip millimeter cryo catheter?
Exactly, that's the one that we used, exactly, yes, yeah.
Wow.
Yeah.
Well, I mean, that sounds like really helpful guidance. And I guess the last thing is you probably, in going through this study, learned some things about the anatomy. What tips would you have for people who are operating in this region? For sure, and I think, looking over these cases was a real education in the anatomy, and it wasn't part of the right ventricle that I considered as much as perhaps I should. Actually, I would say that the most important thing that I learned was really the value of visualizing this as the treatment's being delivered. So again, coming back to this idea of the value of intracardiac echo throughout the procedure for treating these arrhythmias. Wow, that's really helpful. So summarize for the ablationists and electrophysiologists in our audience, what are the three main takeaways from your study?
So I think that these are a rare source of ventricular arrhythmias, and they're associated with difficulty, both with catheter stability and automaticity when RF is used. So I think the main takeaways that I'd like to emphasize were that cryoablation, even as a first line, can overcome some of those challenges. It's extremely helpful to have intracardiac echo to actually guide the delivery of cryoablation, and it probably is reasonable to actually use cryoablation as a first line therapy for these rhythms.
Great. Well, Dr. Whitaker, thank you so much for taking your time to share your insights with us, and I would encourage everyone in the JACC audience to log in and look at the paper and appreciate the science for yourselves. Thank you for joining us today.